If your goal is to try labor without medication, what we suggest is hydrotherapy, so getting up in the shower. That can be really helpful to ease that labor surges. Something else that we suggest is you could have your labor support person do counter pressure on your back. Other things that are really helpful is being up and mobile during labor. We find that women cope best when they're moving around. If you found that those options weren't working for you and you'd found that your labor pain was unacceptable, that's the time when you would want to consider labor analgesia. And Dr. Carvalho can best talk about that.
So there's a number of options you have for labor analgesia. The first option would be intravenous opioids. We generally offer this early on in labor or in patients who cannot receive epidural analgesia. It helps to at least slightly alleviate your pain, so maybe reduce it to around half. But we like to limit how much opioid exposure because of concerns with the baby. The other option is nitrous oxide. It's an inhaled gas. It's not very effective for pain relief, but it does help women cope, and it does give a different analgesic option. And again, we do try and limit it because of gas exposure to a fetus until delivery. And the most effective option is epidural analgesia. About 70% of women in the United States get epidural analgesia, and the reason why it's so popular is because it's highly effective, and because we dose medication in the spinal space, we're able to give the medication where it's most needed. So it's much smaller exposure to the baby and very well tolerated by the mom. Epidurals usually can manage your pain by largely eliminating pain during the first stage of labor, and during pushing makes pain very manageable, usually more just of a pressure rather than a sharp or unpleasant pain. We now use modern epidural solutions which are extremely dilute, so you should be able to not only feel your contractions, you should be able to move around and be able to push quite comfortably without having any issues. We have very good evidence with very big studies showing unequivocally that epidurals do not increase the risk of cesarean delivery. It's been well demonstrated both in well-designed studies as well as impact studies when you introduce epidural analgesia to a hospital and you don't see any difference in the cesarean rate at that particular hospital. For progressive labor, we think on two things. Firstly, your ability to push the baby out and needing assisted delivery. And with modern epidurals with dilute solutions, does not impact that, and women are easily able to push, and it doesn't affect or increase your likelihood of needing forceps delivery or vacuum-assisted delivery. And if there is an extension, it's in the region of around 15 minutes longer pushing phase. I mentioned earlier about opioids would have a bigger effect because we're using larger doses intravenously that go directly into the baby, and also nitrous oxide. If you're breathing in a gas, an anesthetic gas, it can more easily go to the baby. Epidural analgesia, we run very small doses in the spinal space, and we use two drugs, a local anesthetic and an opioid, has a very low propensity to cause problems in the baby, or for that matter affect subsequent breastfeeding in the baby when they're delivered. So it has very minimal effect. Obviously no drug is better than any drug, but in terms of the biggest effect on the baby, the least effect is epidural analgesia compared to other analgesic options.
So as Dr. Carvalho discussed, labor epidurals don't necessarily increase your labor or increase your time of pushing, so we don't necessarily get too hung up on dilation and stage of labor. But what we will tell you is the right time is when you think that you can't do one more contraction. So when you're having real pain that's unacceptable to you, you should get that epidural if that's your plan.
Epidurals are extremely safe procedures. It very rarely hurts. If it's well done, we're putting local anesthetic in, and we stick a needle in below the spinal cord, so we're not going to go through a spinal cord. We actually go on the outside where the nerves exit, so we just bathe them in local anesthetic. So there is a very, very small chance of nerve damage, but we see it in the 1 in hundreds of thousands, if not in 1 in a million. So it's extremely, extremely rare. One thing we do sometimes result in is what's called a post-dural puncture, or a headache that would result from that. It occurs about 1.5% of the time, and it's a complication we can treat, but that is a complication that is sometimes associated with epidurals.
The solutions that are used most often are pretty dilute, meaning that you're getting the lowest effective dose, but we would be concerned that you might fall. So it's best not to walk around with an epidural. and your nurse will help guide you. But we want it to be so that you can move your hips up and down and move side to side, feel the pressure and have effective pushing. Your epidural, as Dr. Carvalho talked about, will last through the duration of your labor and delivery of the baby. We also keep it running if you would need a little bit of a repair, meaning you might need some stitches after the birth of the baby. After that's done, we turn the epidural off. It takes a couple hours to get completely out of your system. Epidural anesthesia increases your chance of urinary retention, so we really prefer to place one. And we want to keep that bladder nice and empty because it also creates extra space for your baby to move down, as well as decreasing the chances of having some sort of bladder injury as well.
The two things that are important is how well you manage routine care, as well as how well you imagine emergencies if they were to occur. In terms of routine care, I think it's essential that you have a dedicated obstetric anesthesia service that is in-house 24/7 with availability of backup to help with emergencies and also reduce waiting time if you request an epidural. Emphasize 21st century epidural analgesia, which is essentially running very dilute solutions, utilizing all available techniques. For emergencies, it's essential that you deliver at a hospital that has the infrastructure to handle them in terms of both staffing as well as the training.
The choice for labor analgesia is a shared decision making, meaning that you are the first and foremost person that's guiding this discussion with your OB anesthesiologist as well as your nurse. And your hopes and your needs are going to be met by that team, and it's a team-based approach. And Dr. Carvalho can elaborate a little bit more on this, how we put your needs first.
So we try and see all, or at least most women prepare to see us early on in labor, and we explain in detail all your labor analgesic options to make sure your needs are being met. And then we do a very patient-centered approach. We have various options in terms of how quickly we can make epidurals work and different doses of maintenance solutions. We have pumps that allow women to dose themselves when they need, and all of these are accounted for, and we watch during the progress of labor and we can adjust accordingly. And we take pride in running an epidural service that accounts for women's needs as well as the safety within our unit. Epidural analgesia is an extremely safe modality. It's extremely effective, and if you feel you need it, certainly ask your anesthesiologist to provide it. And we hear it time and time again when we've finished an epidural, a woman will turn to us and say, "Are you ready, done? Is that it?"
We hope you found this video helpful in exploring the different modalities of pain management during your labor, whether it be unmedicated or medicated. We wish you all the best on your journey through labor.